Hello and welcome everyone to another episode of and Why, which is a series dedicated to really discussing publications in the HIV research and shining a light on the phenomenal women behind this work and their vital contributions as women clinician researchers. So I'm your host, Toyin Wafor. I'm an infectious disease physician, executive director in pharma, and really a passionate advocate, HIV advocate. And in this series, really my goal is to really break down those silos that and move us beyond those firewalls, right, that separate us from amazing research and the authors of these kind of work, and actually the people who need to hear about this and amplify their work. So we'll delve into the unmet needs that prompted this research. We'll explore what was done, and we'll examine their findings and end with why should we care. And that's important. And today I am excited to be joined by my colleague and friend, Dr. Marisa Robertson, who will introduce herself, but we're going to be really discussing one of her publications really around HIV prevention in women. But before we get started, Marisa, Dr. Robinson, welcome, and please introduce yourself.
Well, thank you. Thank you for having me. I'm so excited to be here and welcome everybody who's tuning in. Again, my name is Dr. Marissa Robinson. I use she, her pronouns. I'm your sexual health girly, infectious disease researcher, and a lifelong learner. And I'm here to really bridge the gap that we have seen with specifically Black women in HIV prevention, care, and treatment, but also to normalize some of these conversations because we're having them in the clinics, we're having them in the infectious disease spaces, but we're not having them necessarily in the beauty shops. We're not having them at the HBCUs. We're not necessarily having them in our group chats. And that's where we need to be having some of these conversations. So a lot of my social media presence is about normalizing some of these uncomfortable conversations and topics, but I'm also doing that in the research world and space. And I'm really excited to talk about that today.
Oh, amazing. Great. And you will be able to reach out and continue to find out more about the amazing work Dr. Robinson's doing. This is just a brief glimpse into some of the things that she's doing. So today we're going to be talking about this article that I really liked. It was really one of many, but it was like, the title is, I don't really know much about PrEP, examining Black HBCU women's pre-exposure prophylaxis knowledge and awareness. And Dr. Robinson was the first author on this paper. So, in research, we like to go with background, methods, right? Results, conclusions. And that's what we're doing now. We're going to break those out into really concrete terms. So what? The background is what? What was the unmet need that prompted you to do this research?
Wonderful. So as we know that 1.2 million individuals in the United States are living with HIV. And in this work that we do, a lot of spaces and places, we know that information, but the average person doesn't think or know that data. And so talking about the statistics about the 1.2 million people that are living with HIV is just starting at the surface. And then when we talk about 1 in 5 people not knowing that they're living with HIV, there is really a dark place in terms of where we need to be going and where we are right now in terms of unmet need of not only PrEP uptake, but also awareness. And if you're not aware of something, how can you have the knowledge? And so really the knowledge and awareness of PrEP is some of the key reasons why I wanted to do this work. And so while I was doing my dissertation, I was at a HBCU in the Northeast, and I figured, hey, this is one of the EHE jurisdictions, and for those who don't know, that's the Ending the HIV Epidemic Initiative, which was a federal initiative to try to also uphold some of the HIV research, care, and treatment that we have, but also to make sure that we're diagnosing folks, we're treating individuals, we are responding rapidly, and we have prevention. And so these 4 kind of pillars of EHE and what the jurisdictions were that were highlighted in this initiative. Also, when you put those maps overlapped with social determinants of health maps, when you map them over with redlining maps, when you map them with HBCUs, and you overlap them with things like poverty, asthma, pollution, air pollution, environmental justice, you will start to see a pattern. And so I knew that when looking at PrEP. This was back, the research that I conducted was back in 2022, and yet in 2026, some of this data is still very much valid because 9% of women are PrEP users, 9%, and yet 86% of new diagnoses of HIV were due to heterosexual connections. And so we have got to stop thinking that HIV is a us versus someone else problem. It is a everyone problem because everybody is HIV possible. And when we start to really dive deeper into what does that mean and what does that look like, it means normalizing the conversations. It means talking to students about this and making sure that everyone is aware of not only the resources that are available, but also the different modalities of PrEP, right? Because we only had oral PrEP when it first came out and was approved by the FDA in 2012. But now, 15 years later, we also have an injectable and there are trials going on with a vaginal ring. And so to see where PrEP has gone and yet the conversations are still nuanced, still aren't normalized, that is something that I'm really trying to bring more knowledge around.
Wow, and you're doing such great work. You broke it down. I love how you explained the tenets of the EHE and also some of the overlaps and how all of these things are not happening in isolation. So
Right.
you laid out beautifully kind of the background for this work, right? Where you
Yes.
conducted it. So let's move into that. What did you do? What were your methods into the second what? Yeah.
Yes, absolutely. So we used the health belief model and the socio-ecological model to look at the individual all the way up to the systems of PrEP awareness and knowledge. And so using the health belief model, I asked a series of questions to students that were attending Morgan. And this was also right after COVID. So we have to think webinars, a lot of in online presence was conducted for a lot of research being done. And so I did qualitative research because for me as a qualitative expert and researcher, I thought it was very important to understand some of the nuanced contextual factors that sometimes when you're only doing a survey of a Likert scale of 1 to 5, you're not going to be able to capture some of those anecdotal stories or talking to some of these women to really probe what do you know about PrEP? If you knew about PrEP, maybe they don't know where or how to get it. So just because you have awareness of PrEP, we can check the box. We could say, yay, you know about PrEP. But if I don't know where or how to get it, or if that's not going to then turn around and go into a PrEP prescription, did I really do the best at connecting that person to care? Well, technically, I could check a box as a practitioner to say, hey, they increased their awareness, they know about it, but does that lead to a prescription? Well, no. And quite candidly, I wanted to get into, well, what does that look like and what does that really mean? And so talking to these 22 women, we did a series of 6 focus groups across the January to March of 2022 to ask these women, what do you know about PrEP? How did you get it? And we asked them a series of questions. And then from those questions, we did a little bit of probing in terms of, okay, well, if you did know about PrEP, how did you learn about it? Well, I have a friend who's in the LGBTQ community. Oh, okay, great. Or if I ask them, can you tell me the difference between, what is PrEP? If you know about it, can you explain it to those in the group who don't know? And sometimes some of the women would say, oh, I know about PrEP. It's a pill. You take it every day. It's kind of like birth control for HIV. I was like, yes, I love that. You get it. But then some of the women had a misunderstanding of what PrEP was because they thought it was actually antiretroviral therapy. And so some of them thought, well, this is what you take to treat HIV and to stay undetectable. And I was like, well, that's great that you know what undetectable means and that undetectable equals untransmittable. However, that is not PrEP. So that is another modality, which is called antiretroviral therapy. So making sure that the women came away from the interviews, not only knowing the difference between what PrEP, PEP, as well as ARVs were, but also talking about the different nuances of how did they find out about PrEP, or, oh, I know about PrEP. I've seen the commercials, but those commercials aren't for me. And I don't see myself in those commercials. So I thought it was just for gay people, or I just thought it was for men who have sex with men, or I thought it was for, gay gay or bisexual individuals and not for straight women. So there was a lot of nuances that we unpacked in those focus groups. Now they were only an hour long. So I want to be clear that there was a lot of things that we could have got to, but we also wanted to be mindful of time, fatigue, interviewer biases when you're dealing with and talking about qualitative research. So there was a lot that we learned, and there's still so much that we can do with this information. And this was just one population at one HBCU. But imagine if we did this across the country, and if we looked at some of those different kind of socio contextual factors that happen of the deep South or the far West, or if we're talking about the Bible Belt, or if we're talking about institutions that are very Christian oriented or Catholic oriented or religiously oriented. What do those students know or don't know? So, and this was only talking to women that were assigned female at birth. So what if we brought trans women into the conversation, or trans men into the conversation, or cis men into the conversation? So there are so many ways that we can take this research and build upon it. And that's what I hope that folks will be able to do who come behind me, because this is a lift as we climb conversation, and it's not going to stop here. And I really hope that in the next 15 years we'll have even more modalities of maybe something that intertwines birth control and PrEP and Bicillin. There's so many things that pharma can do in terms of the science and biomedical advances that we have seen, and I just hope that we can continue to push that forward.
I mean, you laid it out so well, and the work that you're doing, like you said, just building on what we already knew. But during those times where you were doing these surveys, you were also deep diving and probing to get themes out of this, right? In a very short time. And like you said, themes in different parts of the country, the geography, the context in which people are could be so different, and probably will be. But it's important to put all of those things, because again, biomedical innovation is great. But the real innovation is actually getting people the tools they need when they need it, how they want it, right? That's where the innovation, the creativity comes in. That's where it comes in. So you already laid out to us why you needed to do this work. You told us what you did with the health belief model and the questioning that you did. So what were your key results and takeaways from this, kind of the what? What did you find?
Yeah, so some of the main takeaways was that the knowledge and awareness sometimes was there and sometimes it wasn't. And so if they knew about PrEP, they didn't know where or how to get it. There was issues with stigma. There were barriers. There were facilitators that we also saw. Cost. Also, if your provider, maybe some provider awareness was not there. And we know now that the Prevention Task Force has made the recommendation, a grade A recommendation, that if you ask for PrEP, you should be able to get it. If you're HIV negative and you have, the right coverage, you should be able to get a PrEP prescription. And so just knowing that awareness was increased was definitely something that we learned and we talked about. Some of the biggest challenges that I think we also heard and were experiencing live was that we were in the middle of a global pandemic. And so for many individuals, going into a clinic, a hospital, or any sort of healthcare setting was very triggering. For some, they lost loved ones. For some of them, they had a distrust of governmental agencies and just public health in general. And so having that distrust of medicine and science, I think we are still dealing with those implications. And when COVID first happened, I think the misinformation traveled a lot faster than the correct information. We had a lot of distrust.
The work that you're doing and your platform and the way you're breaking things down, and you're relatable, but you have the credibility, but at the same time, you're like, ask me anything. That's what's needed to rebuild the trust that we've lost, to start new people, and to be able to have our information that is credible spread just like or faster than the one that's faster. Not. But people need to be relatable and feel like what this person's saying, I get it. I feel like it's legit. Yes.
Right. And we want to make sure that the individuals that need this information the most are the closest to the conversations we're having. So we can't have these conversations in a vacuum, which is why I wanted to focus on college age students, because for some of the students, they were doctoral students, they were master's students. So the expectation societally is that you are You have the college education, so you are
You know
maybe
all
the
this
most
stuff.
well educated, right? This is supposed to be knowledge that you already have. But the reality is, it's not. And even because you're in a metropolitan area or you're in an area that has a high prevalence of existing HIV cases, should not be equated with everybody knows
Knowing.
about the modalities that are in place for both HIV prevention, care, and treatment. And so
And
that is
treatment.
also what I wanted to get at the nitty gritty of these results, was to also understand where some of these students were coming from. If they heard about testing on campus, what did that look like? Have they ever been prescribed PrEP, or have they ever come up with an STD or STI before? And has your provider then said you'd be a great candidate for PrEP? Have you considered it? These are conversations that are not also happening behind closed doors with their providers. So giving folks autonomy to say, hey, you can shop around for a provider. You can also ask for a PrEP prescription, and you can get more information if you ask for it. But sometimes it's feeling confident to do that. And if you are someone who's highly educated and you still don't feel comfortable, how can we expect members of other communities that don't have these credentials to feel like they have the power or the wherewithal to advocate for themselves?
Wow. This just, yeah, you said it all. And that's the thing, because, we've talked about how these conversations need to happen. And there are a lot of people who walk into healthcare spaces. And if their healthcare provider does not bring it up, it must mean
They're not
it's
talking
not
about it.
important, because
Or it's not important.
it means
Correct.
it's not important, or it's not for me, because if it was, they would have talked to
They
me
would have
about it.
said
So when you're
something.
talking to the students, and I love your point about just assuming that because someone has this level of education means that their health literacy is at the same. No, it's not. This is the
Right.
kind of work you do. Or also assuming that they know the local data in their community, or that they know that. And sometimes there's knowing, and then there's connecting it to
Connecting
yourself.
it.
It may just seem
Correct.
very abstract.
Very.
So-
And it's also, we can flip it on its head to say that just
Yeah.
because somebody is of community and doesn't have these accolades or commas behind their names, to think that they aren't educated
know.
or don't know or can't tell a clinician or a community advisory board what's what, and they should be compensated for their time, their knowledge, their expertise, and their lived
Absolutely.
experience. We should absolutely also be uplifting those same conversations and those same individuals to bring them to the table, because we all are HIV possible. And for those that are living with HIV, the onus should not be on them. We should all have a ethical and moral responsibility to care about infectious diseases, and HIV is just one of them.
Absolutely. Couldn't agree with you more. And that's what we're going to have to do to continue to get to where we need to go and to close these
Yes.
gaps, right? Because we've only
Yes.
gotten so far, and then we've stalled. And we need to
Yes.
do all of those things you talked about. And that's why these kind of conversations and really looking at the lived experience and community and true partnerships to
Yes.
be able to move us to where we need to be. So I'm going to close with two things. One is, actually three, very
Okay.
quickly. So you talked about the research, the what the unmet need was, what you did, what your results and takeaways were. I have one question before we ask
ma'am.
the closing one. Why should we care about this kind of work, this kind of research?
Well, we should care because there is a disproportionate impact on Black women, period, full stop. And we know that from the data, we know that from the statistics, and we know it from folks that are living with HIV. We hear it at the conferences. We were just at the Biomedical HIV Prevention Summit in Chicago, and many of the conversations that were had talked about the disparities of the work, but it also highlighted the wonderful advocacy, the wonderful efforts from community to leaders to clinicians to just all of us that are in this work, and how no matter what's going on in the in above board, there are people that are working each and every day to make sure that those who are living with HIV are connected to care, remain in care, and stay undetectable. We have individuals that are re-engaging folks in care. We have folks who are just expanding folks' knowledge around prevention modalities, as well as bringing folks forward from the biomedical advancements that we see. So this was I think this is something that is not going to stop today. It's something that we have to continue to pay attention to and to uplift. And I'm just one of many who are out here fighting fearlessly, no matter who's in charge, to make sure that this is a part of the conversations that we're having, because infectious diseases knows no race, no gender, no sexual orientation, no geographic location. Infectious diseases are everywhere. And so we have to care about it and we have to uplift it, and bringing it to the center of some of the conversations we're having each and every day is what we need to do. And making sure we're having honest conversations is going to help with normalizing the conversation. And because of your platform, I will say that these bite-sized understandings of breaking down some of the complex, peer-reviewed journal processes and what we're talking about, it's great that these are peer-reviewed and that they are seen as, revered pieces of science and medicine. But we also need the average person who doesn't have access to some of those journals, who doesn't understand some of those words and nomenclatures that we use, to understand and to also care about it. So thank you for what you're doing on this platform.
Thank you. And thank you for all the great work you're doing. And so that leads me to our closing, which is, what one piece of advice would you have for someone who's coming, like, as you talked about, lift as we rise, right? For someone who's just starting in this field of HIV and infectious disease, or just HIV, someone starting off, and also what keeps you going?
Yes. So I would say for anybody that's getting into this space, first, you need to observe. You need to listen more than you speak, and you need to come to this work with humility. I will say that as somebody who has been in this work for almost 15 years, I have observed, I have listened more than I have spoken, and now I have gotten to a space where I feel comfortable even talking about some of these conversations and feeling like I can be tapped as a subject matter expert. But the persons of lived experience have PhDs of their own lived experience. So we also need to bring those individuals to the conversation. But if you're getting into this work, we do it because we want to connect folks to care, and we want to make folks' lives better and live longer. And so if you have those same qualities, that will keep you going in this work. But the humility is first and foremost. And what keeps me going is conversations like this, to know that my work is being seen and I'm making an impact. And sometimes in this work, it can feel like, oh, does anyone care? Are people seeing it? And sometimes you won't get the pats on the back. You won't get the pats on the back, or you won't get the recognitions, but you will save populations of people, connecting them to care, connecting their lived experiences and their stories to the greater and larger body of knowledge. And so that is what keeps me going, and knowing that this is just the beginning and we have so much more work to do, but we can be proud of the work that we have done, especially because there are so many Black women who have come before me, who are giants, who have been doing this work tirelessly, and who have gone into maybe the shadows, or have gone to other things, and who have passed away. And so I am just one of the mere vessels that have been put on this earth, because God doesn't make mistakes, and divine intervention and timing is everything. And I hope that this message reaches all of those people who we intend for it to make a difference for.
Well, on that note,
yes,
you just dropped the mic.
The mic.
You just dropped the mic. So thank you for joining us. In the show notes, there will be a link to the full article if you want to read about the methodology. But Dr. Robinson broke it down about the work, all the potential opportunities to continue to build on that work, and really expanding, Black women's awareness and knowledge and understanding and access to HIV prevention. So thank you, Dr. Robinson, for joining me today. I enjoyed our conversation, and I look forward to chatting with you soon.
Yes, thank you.